Okay, so it's just about time to get started. I'm going to allow a couple more minutes for see if anyone else is going to start coming on, and in about a couple of minutes we'll start the programming. Thank you. Okay, let's go ahead and get started for today. Continuing our webinar series looking at antimicrobial stewardship in long-term care. Today we're talking about complicated nature of urinary tract infection diagnosis and diagnostic stewardship in long-term care. And we're honored to have Dr. Surbhi Leekha here today with us. She's an infectious disease physician and associate professor in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. She's also the medical director of the Infection Prevention and Hospital Epidemiology program at the University of Maryland Medical Center. Most of her professional effort is devoted to the prevention of healthcare-associated infections, with a focus on surveillance methodology, implementation techniques, and infectious disease diagnostic stewardship. In terms of diagnostic stewardship, particularly with diagnostic stewardship related to UTIs, she also leads the statewide C. diff collaborative to help decrease incidence of C. diff across the state of Maryland. So with that, I'd like to hand it over to Surbhi to begin her talk today. Thank you.
Thank you very much. It's my pleasure to be here. I don't have any conflicts to disclose, but I would like to acknowledge a couple of colleagues who were instrumental in guiding this talk, because as Kim mentioned, my effort is mostly in the hospital setting, and you know, I can apply some of that to long-term care, but Dr. Rainward Domyati and Dr. David Nace are leaders in the field, particularly with UTI prevention, treatment, as well as diagnostic stewardship in the long-term care facility setting. So hopefully we can benefit from their wisdom. So these are the learning objectives for this talk. The first is to recognize the importance of diagnostic stewardship in preventing unnecessary antibiotic use for UTI, which is the ultimate goal. The second is to describe some tools for UTI diagnostic stewardship for use specifically in the long-term care facility setting. And the third is to identify some diagnostic approaches to residents who have cognitive impairment and change in condition, because that is an important theme and comes up pretty frequently in that setting. So the first point I'd like to make is that a high proportion of urinary tract infection antimicrobial use does occur in patients with inappropriate or unnecessary culturing. And that's the reason why we're talking about how to handle the diagnostic end of things. And it's not surprising that majority of patients who end up having a positive urine culture or even a positive urinalysis, despite not meeting expert consensus clinical criteria for what we would consider a urinary tract infection, end up being treated for UTI on the basis of a positive urine culture. As one example, in this study that was done in Canada among older adults that was seen in the emergency department for non-infectious reasons, interestingly, first of all, a number of patients had urine cultures done for whatever reason, even though infection was not the primary presenting complaint. And then 71% of those that had a positive urine culture ended up receiving an antibiotic. So the whole point of this slide is that once you have a positive urine culture, it's very hard and almost impossible to go back to what had initially prompted the culture in the first place. And the instinct or the, this powerful stimulus is to go ahead and treat the patient. So that really sets us, sets the framework for this discussion. And to add to that, and again, I know this is not new to most of you, and you are very familiar with these statistics, but this is from the older version of the asymptomatic bacteriuria guideline from clinical infectious diseases, but basically making the point or driving home the point that asymptomatic bacteriuria is extremely common. And if you think about the patients that you guys deal with every single day in your facilities, older persons, and those that are living in nursing homes have some of the highest prevalence of asymptomatic colonization with bacteria that may be pathogenic, but not necessarily causing infection at the time in the urinary tract. so ranging somewhere in between 20 to 40 to 50%. But if you add on top of that the presence of a urinary catheter, that goes up to 100% by a couple of weeks in most patients. So then that leads us to thinking about, well, if we know all this, then why is inappropriate culturing so common? Why can't we just not culture? Well, that, as I think most of you know better than I do, is because it's extremely hard. So we know that the prevalence of asymptomatic bacteriuria is high, so we're going to detect positive urine cultures very frequently. But the real issue is that there is a really high prevalence of nonspecific symptoms for which we get cultures. And we have older patients who have multiple reasons to develop change in mental status and function. But the way over the years our ordering practices have evolved is that we have this almost knee-jerk or reflexive reaction to any change in condition for any resident that leads us to testing, and particularly urine testing. Part of it is because it's easy to do, it's ingrained in us. And the second issue is that we often think that UTI is a very common cause of those symptoms. And we'll talk a little bit later about why that might not be the case. And there are also other symptoms that are misattributed to UTI. And the prominent ones there that we definitely need to tackle are the presence of cloudy or foul-smelling urine without any other symptoms, as well as mental status changes, as I mentioned, without any other symptoms. And then the last point, why we tend or err on the side of overdoing or over-testing or over-culturing is that we often do not have the time to evaluate patients fully, and we have a fear of missing true and especially complicated UTI when it does occur. And sometimes that's driven by family request, and that's true both in the long-term care facility as well as in the hospital. So all of this occurs equally in the hospitals as it does in the long-term care facilities. It does at the transitions when patients transfer from one to the other. So these are issues that are common to all of us and we look at every single day. And that is really why the diagnostic stewardship is so important. And the point I really want to make here is that, it's very hard to be successful with just antimicrobial stewardship if we don't tackle the diagnostic stewardship end of it, because as I mentioned, once you have that positive culture, it's very hard to not treat that. So we're saying here that diagnostic stewardship, as you can see, is upstream of antimicrobial stewardship. You're obviously most of the time getting the culture before or sometimes at the same time as you're starting antibiotics, and then basing your post-culture antibiotic decisions on the results of those cultures. So if we are able to intervene at this point and prevent what I call a false positive or an unnecessary positive culture that just represents colonization, then we don't even have to deal with this downstream path of having to stop or modify the antibiotics. We were recently at our Society for Healthcare Epidemiology of America annual meeting, and there were some nice presentations, but this one struck me as particularly relevant. This is from the Michigan Hospital Medicine Safety Consortium. So again, this is more of a hospital perspective, but many of their patients are actually those that are being transferred from long-term care facility to the ED or hospitals. And when they led their efforts to decrease UTI antibiotic use, what they found that 80% of the reduction in unnecessary antibiotic use was due to a decrease in inappropriate testing. So again, it's to drive home the point that by tackling diagnostic stewardship, you can get much larger gains than you would with just trying to tackle antibiotic stewardship by itself. So then that leads us to this next thought of, well, how do we actually do that? And I'll talk about several different things, and I'm sure many of these are familiar to you. If not, I do also have some resources listed at the end, and I would encourage you to look these up even later in addition to this talk, because this really touches upon the surface. There are a lot of great materials out there that you can use to apply in your facilities. So I broke this up into two major categories. The first one is the methods and tools, so just the techniques and the methodologies that you can use. And the second part is more on the practical implementation side, because we know that we may have so many tools at hand, but unless we implement them in a very thoughtful and structured manner, it's very hard to see the success from those. So I try to divide them up into those two broad categories. So we'll go through them one by one. So let's talk about culturing for appropriate symptoms, because that really is the meat of this matter. And what I have here on this slide are just some very general points, general guidance to develop your facility's urine testing criteria. So I do think that's important to do. You may be able to use what's already out there, and I have two examples that I'll share. But what you really want is something that has consensus in your facility from a wide variety of stakeholders, so they're seen as your institutional criteria that you live every single day, and can stand by and say, oh, this is the protocol we're talking about, and everyone knows about, so no one is questioning why things are being done one way or another. Okay, so having said that, what are these general criteria? And the first one, not surprisingly, saying that in most patients, do not test for non-specific symptoms by themselves. The second, and I really like this approach, is because we are worried about missing things in patients who are at risk for complications. So somewhere in your pathway, have a system for identifying what may be high-risk patients, and things that you could use could be just an impressive change in vital signs, or clear systemic symptoms, or evidence of complicated infections such as flank tenderness or scrotal tenderness. Once you have the high-risk patients, you absolutely want to test them for UTI if they have urinary tract symptoms or signs, so make sure that your pathway allows for that. Or if they don't have urinary tract specific symptoms or signs, you still might want to test them for UTI, but most experts agree that you want to do that if there are no other localizing symptoms or signs, such as new or worsening cough that may suggest pneumonia or another source of infection. On the flip side, what you really want to do is, if you currently have any pathway that allows for just automatic urine testing for any change in condition, you definitely want to get rid of that, because that's probably the #1 source of overtesting in that setting. And then not using changes in urine character alone without any accompanying clinical signs and symptoms. And then lastly, no test of cure urine cultures if the patient's symptoms have resolved. Excuse me. So I'm next going to show you a couple of different pathways that others have adopted and have had some success with. So this is one from Dr. Dumyati from the University of Rochester and the Rochester Nursing Home Collaborative. And the way they chose to broke it out was, without indwelling catheter and with indwelling catheter, because we know that the symptoms and signs can be a little different. A lot of people would think of indwelling catheter as being associated more with complicated infection and would treat it that way. So without indwelling catheter, what they say here is that you want at least one of the following signs or symptoms of these sub-criteria. So you want acute dysuria or pain, or a swelling, tenderness of the testes, epididymis, or prostate, so particularly in different signs for men. If you have just fever or leukocytosis, which are more non-specific, then you want to have at least one localizing urinary tract symptom or sign. Or if you don't have any fever, then you want at least 2 different localizing urinary tract subcriteria. So that's one way of narrowing down to patients with true symptoms of UTI. And then with indwelling catheter, they're allowing with just systemic symptoms. But again, remember with that caveat of no alternate site of infection, which is very, very helpful. And then if you have an acute change in mental status or acute functional decline, again, with no alternate diagnosis, but also the presence of white blood cell counts. And I'll show you something else later that also says, if you really cannot elicit anything in a patient who has mental status change, you don't think there's any other site of infection, you probably want to have at least a leukocytosis before you go down the path of UTI testing. If you clearly have new onset suprapubic pain or costovertebral angle pain or tenderness or purulent discharge from the urinary tract, so those would be appropriate. Here is another example, and this one is from Dr. Nace. And I do want to point out that a lot of the things that I'm talking about are also in this Improving Outcomes of UTI Study Toolkit, which is an HRQ-sponsored study that Dr. Nace has been leading, and it's freely available. So at the AMDA website. So that's something you definitely want to look into at some point if you have not done that already. So I also like this example, and perhaps you can think of having something in between the first and the second one, or you can just borrow one or the other if you like one better than the other. This one really tries to distinguish the sort of the low risk and the high risk patients, or I think in this case, more of a simple uncomplicated bladder infection or cystitis, and that's the starting point. But looking very carefully for any signs or symptoms of complicated infection. So they say if you have 2 warning signs or symptoms that suggest possible complicated UTI, such as pyelonephritis, renal abscess, or prostatitis, and those signs and symptoms are listed here. So if you have 2 of these, then you probably want to go ahead and test and even treat depending on how sick the patient looks. However, if not, then you want to think about, does the patient have cystitis? And again, focus on those lower urinary tract symptoms. And again, this is now becomes very similar to what I showed you in the previous slide, where, if it's dysuria, then it gets a higher priority. Otherwise, you want a couple of symptoms to exist together to go down the path of testing for urine. If you don't have any lower urinary tract symptoms, if you don't have suspicion of complicated UTI, you're really ending up in this box saying unlikely cystitis, active monitoring, and evaluate for other cause. So I don't know how many of you noticed, but the one thing that's really striking in both of these algorithms, so both from the Rochester Collaborative as well as this from Dr. Nace, is that they don't really discuss or focus a lot on mental status changes, right? And that is a big deal in what we see as far as the basis for urine culturing every single day. And in most instances, when you actually apply true expert consensus criteria, that testing is inappropriate when done for mental status changes. So again, these are data from Dr. Dumyati and the Rochester Collaborative, where they looked at 42 patients who were tested and what types of symptoms they had presented with. So again, not to belabor the point, but as you can see, the nuanced confusion leads the pack. And not only is it the leading cause, but in 12 of those 15, that confusion or delirium was the only symptom that triggered a urine culture, and that would be the definition of inappropriate testing based on everything we've discussed this far. Okay, so I want to just highlight a couple of things and why this mental status in UTI testing happens and how we can dispel those myths. So the first myth that is widely prevalent is that patients who have changes in mental status or behavior often actually have UTI as the cause of that. The reality is that patients with these symptoms are no more likely to have UTI than actually many other causes of those changes, and particularly medication effects or dehydration, electrolyte imbalances, and so forth. Myth number 2 is that residents with cognitive impairment are unable to report their symptoms. So that is a very, very interesting thing to think about. I think it's a very difficult thing to think about and to overcome, but we'll talk a little bit about this later in this talk. Because the reality is that symptoms and signs of UTI can actually frequently be elicited despite cognitive impairment. And that's perhaps one hurdle that we need to overcome as we start thinking about how to evaluate some of these patients who might be challenging in their presentation of UTI. So I also want to let you know that hot off the press is this paper, which is Clinical Practice Guideline for the Management of Asymptomatic Bacteriuria, the 2019 update that was just published in the last couple of months. And I particularly want to highlight this one statement because, again, it's stating the same point over and over again, but now you're hearing it from multiple experts. And what they say is in older patients with functional and or cognitive impairment with bacteriuria and delirium, defined as acute mental status change or confusion, and without local genitourinary symptoms or other systemic signs of infection, we recommend assessment for other causes and careful observation rather than antimicrobial treatment. So again, another basis for you to start going down this path if you haven't done that already. So as I mentioned, we do want to think about, well, how do we really diagnose UTI or think about evaluating patients who have cognitive impairment, because it is difficult to elicit those symptoms. But I think if we change our way of thinking and go in with this notion that even though there might be limited verbal skills, we can probably still elicit, because they will report symptoms that are truly bothering them and that are acute and a change from before. So the lesson there is that if you have a patient or a resident who has a diagnosis of dementia, just because they have that label should not stop us from asking about those symptoms. But again, as I mentioned earlier, I think we all need to acknowledge that that is time and resource intensive, and it really comes down to how much you want to invest in going down that path. But if you are invested, then you want to take time to obtain a history. And again, I'll show you some examples of specific questions. You want to ask for presence of symptoms that are specific to the urinary tract instead of more open-ended. You also want to do an exam, and some of these exam findings are not super hard to elicit. So you want to look for tenderness of the flank area, of the suprapubic area, as well as scrotal areas in men. And I think this last point is really valid. You want to repeat your questions, and I would add to that, even repeat your exam to look for consistency of responses, because the more often you do that, and you find that you have the same finding, despite some cognitive impairment, that it's more likely to be accurate or true. So this again is from the IOU study toolkit, and they have this very nice box on evaluating long-term care facility resident with dementia for possible UTI. So I definitely urge you to look at this if you haven't, and have this distributed or used as an educational tool for your staff. So again, it's not without effort, because it does require that you try to elicit these responses in a relatively quiet setting where you've minimized distractions, by turning off TV, any music, closing the door. Preferably you've established a rapport with the resident, or get someone who knows the resident well to try and elicit some of these responses. Again, having instead of open-ended, having more of a close response and say yes or no, and if possible using visual clues, giving the resident time to respond to questions. We are in a hurry because we have lots to do, and we'll say, oh, do you have dysuria? And we don't even wait for them to say yes or no, did they understand the question, and move on. And particularly in this population, when you're asking these questions, rephrasing them using a variety of different descriptions of that particular symptom. So when you're saying dysuria, I know I often say, does it burn when you urinate? But you might also want to make it slightly different and say, does it hurt when you pee? Just rephrasing those questions, asking questions and asking them repeatedly will probably increase your chances of getting a better response. And then again, not skipping on the exam, because those again become more objective, and As long as the patient is even slightly awake, you should be able to elicit tenderness if it is truly present. Okay. So again, I think this is something many of you are familiar with, is the Choosing Wisely campaign of the American Board of Internal Medicine Foundation. And many societies, so our society, SHE, has submitted one of which is urine culturing, but I specifically wanted to highlight that AMDA did it as well. And, out of, I think, the 10 things that they say, where we overdo and to not to do, one of them is don't obtain a urine culture unless there are clear signs and symptoms that localize to the urinary tract. But the other reason I highlighted this is because they also talk about this dementia issue, and I pulled that portion out. And, this is, again, along the same lines as the asymptomatic bacteriuria guidelines and what's in the toolkit. But I think the AMDA is giving maybe a little more leeway, because they are saying that, okay, you've tried your best to elicit symptoms and signs, you have nothing. So you have a patient with advanced dementia who's really unable to report any urinary tract specific symptoms or signs. So in this situation, it might be reasonable to obtain a urine culture if there are signs of systemic infection. But they go on to say, in the absence of additional symptoms such as a new cough, to suggest an alternative source of infection. So I think I've said this multiple times only to highlight that everyone is saying the same thing in a slightly different way, but trying to hone in on this idea that just because you have some change in status doesn't mean that they have UTI. You really need to make sure there's nothing else going on. They are either urinary specific symptoms, which you've tried really hard to elicit, or that there are systemic signs that are leading you to think about UTI. So this is really the summary of the UTI diagnosis pathways. The first thing you want to do is distinguish between high risk and low risk patients. If you have high risk, you want to move on to provider evaluation for possible complicated UTI. If you have symptoms localizing to the urinary tract, you want to perform testing. If you have mental status change and baseline cognitive impairment, you want to try very, very hard to get a good history and exam, and then test either with systemic symptoms or in the absence of symptoms that localize to other organs and point away from UTI. And then finally, if you have low-risk patients without any urinary tract specific symptoms, that's where you can institute what is called a delayed action protocol. So I know I'd done a little bit of this when we had done the kickoff meeting, but I want to talk a little bit more about this because this is such an elegant approach that if used appropriately can go a long way in reducing unnecessary testing. So let's talk about delayed action protocols. So what are these? These are alternative pathways for low-risk patients who might be presenting with vague symptoms and an unclear diagnosis. And why do we want to adopt this protocol? So one reason is that you don't often have an opportunity for immediate evaluation, particularly by a licensed provider. And, we are in this culture of, if you're not doing something that may be viewed as a negative by either, other healthcare workers or by family members or by the patients themselves. And that often ends up with the default of culturing with or without empiric treatment. And how do you apply this idea of doing something that is not testing is by promoting a structured observation as a meaningful action. And that's been shown in the setting of an educational intervention to reduce prescribing for UTI, that actually when they just said, wait and watch, they did see an increase in observation and monitoring interventions and did not see any adverse effects as a result of that. So it can be used successfully if it's applied the way it is intended and also applied to the right patient population. So this is a sample monitoring tool for a stable patient, which means also a patient who doesn't really have any urinary tract specific symptoms. So they have non-specific symptoms and they don't have any systemic symptoms or signs to suggest that they are going to end up with a complicated, sepsis-like picture or a complicated UTI. And, this is one example, but if you go through this, it just says that, we're setting up protocol to say, okay, we'll just carefully observe this patient. We'll get vital signs and we're getting orders from the provider. So this is a way of eliciting certain orders that are anything but testing. So, get vital signs every so frequently, record the patient's fluid intake, make sure that if the resident is not taking enough fluid in, that the physician is notified. You actually actively offer fluid to make sure that the hydration status is kept up with. And then you have a plan for notifying physician in a certain amount of time if there is really no improvement. You might want to get some blood work because, as we talked about earlier, leukocytosis can help us make that decision if we want to proceed with more testing for certain infections. You also want to consult a pharmacist. I mentioned earlier that medications can often be a culprit. They don't have to be newly started medications necessarily. And then contacting the physicians or other providers with an update at a given time. So this may be one way of thinking about delaying that testing and yet not leaving the patient with doing nothing. You are actually doing something in a very structured way, and you're doing something that's actually more appropriate because you don't actually know what's going on with the patient. And one thing that can help with this, and that's the last sort of concrete tool that I'll mention, is the SBAR communication. Again, I'm sure that many of you use this routinely. I think it's a great tool. So again, SBAR stands for Situation, Background, Assessment, and Request. So in this case, we're really trying to use the SBAR for communicating the patient's, risk and whether or not they should be tested. So you're saying you're concerned about a possible UTI. And when I say you, it is likely the staff nurse or a nursing assistant. You may want to communicate whether, in your opinion, this is high or low risk. You want to give some background to the physician or other provider on the resident's brief history and other diagnoses. You want to include whether they have an indwelling catheter or incontinence at baseline, or if they have dementia, because that goes into how we think about eliciting the different symptoms or signs. Your assessment, and again, this is where your facility protocols come in so handy and say, oh, I went down this path and I think this is my assessment. This may be a low-risk patient. And what is your request? Are you requesting just an observation and monitoring parameter, or are you requesting test or antibiotics if you think the patient is higher risk? And beyond just thinking about the SBAR, what I really, really like and I want to share is this is a nice suggested SBAR, and this was just presented by Dr. Cernich, who also works with Dr. Nace on the long-term care facility UTI stewardship. But what a nice way of framing your assessment to the provider, because you've already nudged them towards doing something that you think is appropriate. So you're saying, according to my assessment, this resident is experiencing a low-risk change in condition. I would like your permission, so you have a request for orders there, but it's really to initiate our active monitoring care plan. Sorry, that should be plan, not plain. I would not recommend testing the urine or starting antibiotics at this time. That's a very, very powerful nudge, and it makes the provider feel comfortable too, that even though they're not there to assess, you have a nice assessment and you have a plan for monitoring and follow-up. So those are the tools, and then the question is, well, can we implement them, and what are the other things that might help us put them into action? So the first thing I'll talk about is this idea of a cross-disciplinary approach. And, I purposely use the word cross versus multidisciplinary, which, we often do. Many of the things we do are multidisciplinary. You have physicians, nurses, pharmacists, infection preventionists, and other healthcare providers in the long-term care facility, and you also have family members. But the cross-disciplinary suggests that you're actually assuming a role that is traditionally held by one type of healthcare worker. So as we know, ordering of tests is traditionally a provider role, but really the urine culture decision pathways and protocols and implementation of these requires other disciplines to think about urine testing and having a role in doing that, and in fact being the guiding person to say what that end point of test versus no test is going to be. So it's going to involve nursing staff, probably your infection prevention lead, the pharmacist, and the family member to all be on the same page about whether or not that urine culture is necessary at that point in time. And the medical director still needs to empower and facilitate, because if they agree that this is the pathway and everyone is then speaking the same language, then everyone can have the same assessment and thought process for that particular resident. Having said that, so even though you're crossing over from your traditional role into, thinking about whether that ordering or test order is appropriate, there are still some activities that do need to be done in a more multidisciplinary or team-based manner, and that would be, I think I mentioned this earlier, developing your protocols and doing that in a team or a group, and that includes the ordering protocols, but also the delayed action protocol, agreed upon SBAR language. So, if nursing agrees that this is the language they're going to use, it's really important to make sure that the physicians are on board with that language, that what you're saying or the message that you're trying to deliver is received in the same way by the provider group. And then, education, which again, I'll talk about a little bit more, is always a team-based activity, and that includes involving your families as well. The important thing is that when you're developing these protocols and tools as a team, they are more likely to be used as intended, as opposed to just being handed from one person to the other who wasn't involved as a stakeholder from the get-go. All right, and then there are individual responsibilities. As I said, the medical director is that, the sponsor. You may also have executives that could be the sponsor for your urine culturing initiative. The nursing staff, again, I do think that this, for better or for worse, ends up heavily being in the realm of the nursing staff, because they are the advocates who are closest to the patient family and will need to assume the role of a champion. And I'll spend some time talking about the champion piece. Infection preventionists and pharmacists I want to include here as members and advocates for appropriate urine culturing, because they each have a stake. The infection preventionists in tracking the number of UTIs, they can also track your urine culture orders. Now I know that in the hospital it's really, tracking is very different because it's very heavily dependent on electronic data mining, which is not the same in the long-term care setting. But that's why your IPs who are so tuned with data collection can help track you for a limited time period, track your urine culture orders, to look at the indication if those were appropriate based on your guidelines. And the pharmacist can track the antibiotic starts for UTI, any adverse events that were related to UTI antibiotics. And I know you've had some talks on antibiograms. Not to say, because we're not talking about treatment here, but just a knowledge of the resistance rates can perhaps provide an impetus for thinking about diagnostic stewardship and appropriate culturing, because if your resistance rates are going up and you keep on culturing and treating false positives, that's that's just going to get worse, and you may risk losing most of your oral options. So again, everyone has a role in this task. So let's talk about this idea of a champion. I'm a big fan of this, and I think it can take your project a long way and really help very strongly with implementation of any intervention. So go and find your bedside champion if you're going to take on urine culturing. And again, my perspective is more in the hospital healthcare epi side, and that role of the infection prevention champion is well described. But I'll take that, and then I think you can model that towards urine culturing as well. So what is a champion? A champion or champions are respected individuals with strong communication skills who are knowledgeable and enthusiastic about the topic at hand. These frontline personnel promote and lead healthcare-associated infection prevention, or you could have any other initiative, by engaging and educating colleagues, solving problems, and communicating across all levels of leadership. So the CDC actually has a very nice web page devoted to this, and you can see here the word cloud that they have and what types of attributes you're looking for in a champion: someone who's passionate, who's respected, who's credible, and then who's also a good communicator, committed, courageous. So, and I have this listed in another slide as well. I'm not going to go through all of these, but this just, is a very nice web page that you also might want to visit if you're thinking about having champions for urine culturing, because they can really make a big difference in how you implement this. Again, the same point, but I think these are very powerful data. So these are data from our hospital from a study that was led by my colleague, Dr. Carrie Tom. We had in our surgical ICU really high rates of central line-associated bloodstream infection, even though, so that's this black line that's going up and down till July 2010. The rest of the hospitals shown in gray, or the other ICUs, were coming down nicely, but the SICU really couldn't get a handle on this. So they instituted this idea of having a bedside champion that they call the unit-based quality nurse. And this graph below shows over time the proportion of days of a month that the nurse was present on the unit. And what was really striking to us is that when these days were high, their CLABSI rates went down to 0. When these rates were low, because the person was working not full time, but she was present whenever she could be. When this dipped, this went up. When this became high, their CLABSI hit 0. So the data was so powerful, and we've used this over time to implement infection prevention champions throughout the hospital and see many successes with that in multiple areas. So just quickly, the urine culturing champion can have many responsibilities. They do have to become sort of these knowledge experts of whatever it is that you're trying to implement. They can then disseminate those protocols. And I will tell you, our champions become very, very creative. They do quizzes, they do prizes, they get their manager and director to buy in and sponsor team activities. They also perform audits, and that's a big deal. When you have those bedside audits that unless you have a dedicated person doing those and getting some real-time data for feedback, it's very hard to say how things are going. And then they serve as a resource because they've gained that knowledge, they've gained that credibility. They can troubleshoot, if one of those CNAs or nurses is uncertain about whether or not to do testing, they can always have them as a resource. So there's no question that a staff nurse is ideal in this role because they are that natural liaison between the patient, provider, the pharmacist, and the family. What really needs to be thought through is whether they do that while they're also assuming their regular duties, or do you want to invest in someone to do this outside of that and have some dedicated time to this role. And it doesn't have to be obviously limited to urine culturing. You could bundle a couple of initiatives together, but not make it too much. At least to begin with, if you go down that path. And I think I mentioned some of these personal attributes on a previous slide, but these individuals, should be those who are themselves early adopters, looking for change, feel empowered to speak up, have some energy, enthusiasm, and can communicate with different members of the team as well as with families and residents. All right. And then moving on to education, it's a word that I dread because, we set up so many things and we want to implement so much, but it's so hard to do if you haven't educated everyone on that change that's coming. So again, it's difficult, but critical. It has to be ongoing. You can't just do it one time. It has to be, I didn't say this or have it on my slide, but it has to be multi-modality. You do some in-person huddles, you can do some by email if you do that, you can have printouts or handouts, and you can have wall posters. It has to cross all healthcare worker roles, and especially in the long-term care setting, it has to include families because they will advocate for testing and treatment. You can obviously utilize internal as well as external experts, those that are trusted to provide information, whether it's your medical director, if a consulting infectious disease physician or pharmacist, or infection prevention, a nurse who might be willing to do, a talk. We often get external experts. So, we obviously have the academic hospital and we have access to a number of internal experts, but I will say that getting someone external is often seen as, someone often with more authority than you afford someone who is, your own. So think about that. And then within your education, make sure you talk about outcomes of things that already occurred. So what did we learn from sending a urine culture in a particular patient or not sending it? Was it something positive where you employed a delayed action protocol that led to an alternate and correct diagnosis in a patient? Or was it a negative where an inappropriate culture led to unnecessary treatment and adverse effect? When you actually combine your audits and feed them back in the education loop, then it becomes very, very powerful. There are these, I think, a few talking points that everyone should be on the same page on. So make sure that those are included in your education bullets. And again, it's not a surprise that this is what we're honing in on, but saying that nursing home residents, including those with significant dementia who present without urinary symptoms, are no more likely to have UTI than any other cause of acute change in condition. And unnecessary urine culture may delay that true diagnosis and lead to unnecessary antibiotics and adverse effects. And finally, talking about data review and feedback. This is the last couple of slides, I think, that I have. So you don't want to implement something and not be collecting data. And then if you do collect data, you don't want to just sit on it. You want to feed it back to the bedside people and everyone else, and then higher up as well to your executives, again, to make sure that everyone is looking at this if it's important for the facility. So what are the facility level metrics that you want to look at? And again, you don't have to do everything. Think about what you can collect, what your champion can help with, what your infection preventionist can help with, what your pharmacist can help with. Urine cultures per month, those that did not have an indication, the breakdown by indication, similar to what I showed you, because that can be very instructive in, how many are you doing for mental status change. At the provider level, now this gets really tricky, but again, very, very powerful if you can get this, is, if you have, say, 4 providers that see your patients, can you compare the total number of urine cultures in a certain time period for each one? And is there someone who is an outlier? And if they are, then the medical director really needs to review them and talk with them on why that might be. Are they just seeing more patients, or is it truly that they have a different practice that perhaps needs to be modified? And sometimes you don't even have to say anything. Really, once you share the data, it does make people think about, well, why am I different than others? Is there something that I need to do differently? And then patient level. I think we've discussed at the beginning at the summit and subsequent workshops on this idea of doing root cause analyses, or what are sometimes called apparent cause analyses, or contributing factors. When you look at your UTI cases, and I'm pretty sure a lot of you are already doing this, you want to have as a distinct question, was urine culturing appropriate? So not just was the antibiotic treatment appropriate, but was that culture sent in a setting that warranted it? And then adverse effects of treatment, if any. So you could have potentially something negative there, but as I mentioned earlier, the positive stories can be very powerful. So when you do have an example where you delayed testing and when you had an appropriate evaluation of mental status change, leading to an accurate alternate diagnosis being made, that's something worth sharing, that you perhaps wouldn't have achieved that quickly if you went down the path of a false positive urine culture. Similar to reviewing outlier clinicians, you also want to review outlier residents. So are there certain patients who are these, we call frequent flyers in the hospital, but just frequently tested because they get labeled with chronic UTI when all they have is this chronic bacteriuria that's asymptomatic and may have other causes of change in condition. So really thinking about, what's going on with that. Or they may actually have UTI and something that's modifiable with better bladder drainage and so forth. And then for all data, make sure you feed it back in your regular and ongoing trainings. I'm bringing back that same point I made in the education section, because it does allow your education to stick. All right, we're at the end. I just want to finish up with the key take-home points. So you definitely want to implement diagnostic stewardship as a critical adjunct to antimicrobial stewardship to prevent unnecessary urine culturing and treatment. To do this, you want to develop facility-specific protocols where you can identify clearly your low-risk patients where you can take delayed action, but also guide appropriate evaluation of mental status changes. Use an SBAR for communication of that low-risk change in resident condition that nudges physicians away from urine testing and treatment. And then to implement all of these, identify a urine culture champion that can facilitate urine testing stewardship at your institution. That's all I have, and as promised, these are the resources which I think are very, very helpful if you want to take a look at some of these toolkits and web pages. They will help you quite a bit. That's all I have, and I would be happy to take any questions.
Thank you, Surbhi. So questions can be either through the chat bar, or we can unmute you to ask your questions to Surbhi via phone as well. Well, it looks like so far we don't have any questions. If questions do come up, we do have our office faculty hours on May 15th. It will be I believe our last one on May 15th, and you can ask Surbhi questions about this presentation at that time. So if you think of something after today's presentation, please feel free to join us on Wednesday, May 15th at 1 to 2 p.m. If there are no other questions, I see the participant list is dropping off precipitously. If there's no other questions, I think we'll go ahead and end today. Thank you again, Surbhi. We really appreciate it.
Thank you.